So hello to everyone. We will have another e-ICSM chat with Professor Jean-Louis Vincent and myself.
Hello,
hello. Discussing about what we think at relevant recent publication in different domains. So I will start with some information about COVID. I'd like to highlight this letter to editor published in Intensive Care Medicine, where the authors have shown that in 37% of patients admitted for COVID-19, you can find autoantibodies against type 1 interferon. And in particular, when the autoantibody is able to neutralize the interferon, these patients, a very small cohort, has a high probability of multiple organ failure, ICU admission, and mortality. And maybe in the future, we could use this kind of screening to identify different targets, for example, to manipulate the immune response, potentially eliminating these autoantibodies using, for example, plasmapheresis. The second study I think is very relevant to cite is this paper from Brazil. I think it's very interesting because it deals with more than 13,000 ICU admission over 6-month period. With this trend in mortality we have observed also in Europe, a huge peak in June and then going down in summer period. They showed, for example, that besides age, the frailty of the patients was a main determinant of outcome in this large data set. And I think it's very interesting to report that outside the clinical trials in the real life study, the mortality of patients requiring invasive mechanical ventilation for COVID-19 is very high. It can go up to 60 to 70%, and of course, is an independent predictor of poor outcome. So I think it's an important message to come from this real life study. Now, I would like Professor Vincent maybe to discuss a little bit about therapy in SARS-CoV-2.
Yeah, I was interested in this trial on convalescent plasma in adults with severe COVID-19. The number of patients is relatively limited, but it's published in an excellent journal that intensivists may not read very often, the JCI. And as you can see at the bottom, there were two groups, one with convalescent plasma, but the other one was not treated by placebo. It was controlled plasma. And as you can see, there is a significant reduction in mortality rate in patients who received the convalescent plasma. They had a higher survival than the others. So, you know, this is quite interesting because we know that the studies on plasma have not been so encouraging, except for another one from Argentina that we discussed at an e-chat before. But if we look at the next slide, I'd like to remind us the results of the recovery platform published in the Lancet last week, showing absolutely no difference in outcome. And here the numbers were much higher. We are speaking about more than 10,000 patients. So these are very impressive data in numbers of patients. As you can see in the control group, they did not receive plasma. They had the usual care. So, you know, the debate is still there, but if plasma can have a beneficial effect, it should be given very early on. That appears more and more when we look at all these data. Next slide, please. In general, we insist on the fact that precision medicine should be applied in COVID-19 next, because what we do today is primarily look at the severity and indeed the time factor. When the patient arrives in the ICU, we focus on the host response and no longer on the viral replication. That's about all we do. Sometimes we add a CRP level. But as you said, Fabio, perhaps identifying some other biomarkers could guide therapy. Next slide. So that I was very intrigued by this recent viewpoint in the JAMA from our friends from Pittsburgh, emphasizing that we could actually look for phenotypes in COVID-19, and there are different criteria that we could use to do that. I think it's an interesting thought. Next slide, please. And finally, I'd like to call your attention on this paper, which was published last week in Chest, because it's really thoughtful about the family presence for critically ill patients with COVID-19. Next one. And this is, of course, a long list of recommendations, but I think it's interesting. And in particular, the question is raised whether the relatives could be present more regularly at the bedside. On the one hand, ethically, it's certainly desirable, but next slide. On the other hand, we must realize that sometimes the absence of relatives at the bedside could facilitate the difficult decisions of stopping therapy in patients when their outcome was really grim and when there was a real need for beds for other patients. We should remind ourselves that the rule of the first come, first served should not be applied in pandemics, so that sometimes we have to take the bed of someone who is already in the ICU to try to help another person having better chances of improving. So, Fabio, what else have you seen?
I have another article. I think it's important, despite that the court is very small in COVID-19, which is this report from the cases that have received lung transplantation after severe COVID-19. The authors have reported 12 cases. They could not really take the data from cases in China and Korea, but these are the cases that after COVID-19 with the disease who have not evolved at the levels of the lungs have required lung transplantation. Just to mention a few things that I think are very relevant. This is the chest CT scan of a patient who required lung transplantation. Almost no way to recover without lung transplantation. These patients, 83% on tracheostomy at the moment of transplantation, 11 out of 12 on extracorporeal life support therapy, but the most of cases with awake ECMO. So I think it's not only the concept of lung transplantation, but how you bridge the patients to the lung transplantation and the investment of the ICU staff in terms of rehabilitation and keeping them awake that make this lung transplantation possible. So I think it's a nice paper, of course, very small cohort, very exceptional situation that people should remind this could happen after COVID-19.
Yeah.
The two last studies I would like to mention, one is on my preferred topic, which is the neuro. So it's a nice randomized clinical trial from France. The authors have investigated whether 20% hypertonic saline given since the admission after traumatic brain injury could change the neurological outcome at 6 months when compared to standard of care in this patient's population. And the idea came from a phase 2 conducted from the same group, showing that there was a reduction of ICP and a trend towards a better neurological outcome. These are the data on blood sodium. Of course, you give hypertonic saline, the sodium is higher, and intracranial pressure in general is less higher with less surge of elevated ICP in the intervention group. Unfortunately, they could not show any difference in outcome. These are the data on mortality at 6 months, it's secondary outcome. You see it's a 4.8% difference, absolute difference in mortality. But when you look at the probability of good neurological recovery, it was almost similar into the groups. So you could maybe have less surge in ICP giving a prophylactic hypertonic saline, but they could not show a difference in terms of neurological outcome, which again underlines the complexity of managing TBI patients in the ICU. And the last article is an article from Denmark. It's a national registry of all ECPR in the last 10 years. And I think it's a nice paper for two issues. The first one is that they show that together with the very well-known factors that should prone a physician to use ECPR, shockable rhythm, witness arrest, time to ECMO very short, there was this parameter, signs of life, which is not very well reported in other registries. So patients with visible signs of life, at the moment the physician decides for ECPR, have a better outcome of those patients who do not have signs of life with similar characteristics, shock, type of rhythms or duration of time of CPR. I think it's very interesting. We should more focus on signs of life for ECPR patients. Another issue is that if you use properly the criteria to select ECPR, which should be directed to very selected patient population, then you see that compared to those who were cannulated without respecting this selection criteria, the outcome was much better. Again, underlying that ECPR looks very nice, but you need to identify the good patients to potentially obtain the better outcomes. And of course, we all wait the results from the Prague study, which has been completed, which I hope published soon, which is a randomized trial investigating ECPR versus conventional CPR in these out-of-hospital cardiac arrest patients. So
where was this one published, Fabio? It's not.
It was published of course, in Critical Care. It was published.
Very good, very good.
So this was my last item. I think we could discuss rapidly about a few publications which has been recently appeared in high impact factor journals. And we will hope to have another similar discussion in next weeks to come for another EasySem eChat.
Very good. Fantastic.
Thanks
Have a good day. Bye-bye.
Thanks a lot. Bye-bye. Bye-bye.
Ciao. Ciao.